All right, so this case is about wide complex tachycardia. This is a very interesting case. This case was sent to me by Dr. Amanda Baker. She was one of the Monroe residents who graduated a couple of years ago. Now she's attending. She's a very fine attending, and this case will tell us why. Before we go on to the case, I put these videos out for education, and I'm a weird guy and I'll say a lot of weird things. But the thing is, being a doctor, in my opinion, is not necessarily about what you know, it's about how you think. And some of the best ways to train to be a physician, in my opinion, is number one, playing chess, and number two is doing riddles. Riddles help you learn how to think around corners. So the question is, well, what's unique about this number? It's an exercise for you to try if you want to. Let this percolate around in your mind. Don't Google it. Don't get the answer from someone else. Just think about it, for a couple days. And think about it from different angles and see if you can figure out. The next video, I'll put up the answer. All right, so here's the case. Patient presents with shortness of breath. 70-year-old male who presents with shortness of breath and a fib. States he has a distant history of AFib when he was in someplace else and had an ablation. He has been in AFib for about the last month. He follows with a local cardiologist. He saw the cardiologist last week and his flecainide was increased. He has an appointment coming up at the end of this week for a repeat EKG to see or to determine if he needs another ablation or not. He states symptoms have increased yesterday and even worse today. If he tries to walk a short distance, he will get severely out of breath. Feels like he's running a marathon. Patient is on chronic Coumadin. Okay? Remember, I'm going to say this every time, you don't treat an EKG, you treat a patient, and the value of any EKG depends on your pretest probability. So here's our pretest probability, right? All right. So Dr. Baker, as you should always try to do, found an old EKG, and this is his EKG from 2024. Same thing. Pause, write down what you think, and then think about what your interpretation is. And remember, interpretation is the action of explaining the meaning of something. All right, so here's my findings and interpretations. Number one, we definitely have normal sinus rhythm with a normal rate. There is one P before every QRS. There is an abnormal morphology of the P waves. They're kind of large and double humped in 2-3 and AVF, and almost biphasic in V1 and V2, which can be a sign of left atrial enlargement. The axis, I would say, is left. It's up in 1 and down in AVF. For the intervals, I don't see any definitive widening of the QRS. We do see, like I refer to often, a fractionated QRS. It's this slight delay in the QRS, but it's not a block because the QRS duration is less than 120. You can see it right here in AVL, this little slurring of the S wave as it comes down. You can also see it here in V2, this little notching of the QRS, both here and there. And as far as intervals go, I don't see any, like I said, no widening QRS. I don't see the QT is prolonged. And as far as ST wave goes, looking at the J points and comparing to the PR segment, I don't see any definitive J point deviation. There is some non-specific ST wave abnormalities, but I don't see anything that's hyperacute or concerning. So my overall impression is, this is a normal sinus rhythm with the left axis deviation, no acute signs of infarction or ischemia. There is signs of underlying structural heart disease. And I also forgot to mention there is a left anterior fascicular block. Okay, it's down in 2-3 in AVF, up in 1 in AVL. That's a left anterior fascicular block. I'd also say there's suggestive signs of structural heart disease like we talked about. We got the fractionated QRS and the abnormal P wave morphology. There is also a slight delay in the PR segment, like a borderline first degree AV block. I don't mean to be blunt, but I don't really care about first degree AV blocks. As far as my interpretation goes, I would be curious that these abnormalities in the atrium and the fracture QRS would be either, number one, from his previous ablation, which we know about, right? Like he had part of his heart muscle burned, so this fractured QRS could be from the electricity going around that. Number two, you could have a valvular abnormality too, like as the valve stretches, either which could be the cause or result of his atrial fibrillation. It takes longer for the electricity to go around, which could explain that fracture in QRS. All fancy things, but is it really relevant? Meh. All right, and so here's the EKG when Dr. Baker saw him. Once again, pause, write down your findings, and think about your interpretation. All right, so this EKG is super jacked up, okay? So number one, let's start with the rhythm. The rhythm is irregular. I cannot definitively tell what the rhythm is, okay? I don't see any real clear-cut P waves. Like in the parts where it kind of does slow down, I don't really see anything clearly. So the rhythm for me is irregular and indeterminate. All right. The axis is once again left. Okay. It's kind of difficult to assess, but it is definitely up in one and down in AVF. Remember, when you have EKGs like this that are very jacked up, it's hard to see, well, where does the QRS and when does the QRS start? Again, my recommendations is to remember all of these beats are the same. So this beat in lead 1 right here is the same as this beat in 2 is the same as this in 3. And you can see, like, here's the peak of the QRS, and we follow it up, like it's definitely up in lead 1. As far as intervals go, they are definitely messed up. Number 1, look how wide the QRS is. Like, look at that. That's 1, 2, 3, 4, 4.5, almost 5 small boxes. That's wicked long. Number 2, in real life, the machine will give you the numbers, and you can use that to give you the QTC, but a good rule of thumb is that the T wave should not fall halfway between each QRS point. And again, remember, all these beats are the same. And if we look around, like here's 1R, here's 1R, here's the midpoint, and the T wave definitely falls on that. So I'd say the QT is prolonged, and the QRS is prolonged as well. For the T waves, I mean, we have definitely many T wave abnormalities. Okay, they're hyperacute. I mean, if you look at this, like the amplitude of this T wave is pretty much the same amplitude of this QRS, almost approaching like the sine wave pattern. So my overall interpretation is this is super messed up. Okay, and let's look at the rate. Okay, again, remember the machine will give you the rate, but this whole EKG is 10 seconds. So we can just count the beats and multiply by 6. This is like half a beat. So like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19 and a half times 6 is less than 120. Okay. So the biggest thing about this EKG in this case is you could be tempted to call this ventricular tachycardia, but remember the rules for ventricular tachycardia is you can't call it VTAC if, number 1, the rate is less than 130, or number 2, the QRS duration is over 200, and we have both of those here. Dr. Baker, being the astute physician that she is, knows that flecainide is a sodium channel blocker, and she also knows that flecainide has a very narrow therapeutic index window where it works, and you can get very toxic very easily. And from his history and his pretest probability, she knew that his dose was increased recently. She also knew that the treatment for this is sodium bicarbonate. So she gave an amp of sodium bicarbonate, and this is the EKG afterwards. Sorry about that. There was one other thing I forgot to mention. So I've been talking about fascicular blocks recently. People get confused with the fascicular blocks. I want to show you something here. I mean, you could be tempted to say that, hey, there's a fascicular block here, right? Like it's down in 2, 3 in AVF, it's up in 1, and it's up in AVL. I mean, and you're right. I mean, that does qualify for a left anterior fascicular block. But when we look at this closer, I mean, this is a left bundle branch block appearance, right? Like it's wide and it's down in the precordial lead, so that's a left bundle branch block appearance. When you have a left bundle branch block, you're blocking both the anterior and posterior fascicle at the same time, okay? Because remember your heart anatomy, like this is a pretty good representation, simple representation. Like the right side is just one single pathway, okay? The left side breaks off into the anterior fascicle and the posterior fascicle. And this also highlights that the anterior fascicle is more often blocked because it's smaller and carries less voltage than the posterior fascicle does. And we know this because, when you have a left bundle branch block and you block this out, you just have one smooth appearance of the QRS, right? Like here, we just have this one smooth appearance. That's because we're seeing like the voltage going down this one branch on the right side. And then when you have a right bundle branch block appearance, that's why you get I hate when they say bunny ears. You should use your medical terms. It's an RR prime. And that's why in a right bundle branch block, the first R is always smaller than the second R. The R prime is always bigger. That's because we're seeing this when it gets blocked. So don't freak out too much about the fascicular blocks. Remember, for me, I only get concerned about a fascicular block when there is also a right bundle branch block. And once again, this is his EKG after she gave him the flecainide. Again, we have multiple abnormalities. We still have this sinus arrhythmia. Hard for me to tell if it's underlying atrial fibrillation or just premature atrial contractions. Number 2, the left axis and the left anterior fascicular block. Again, we still see the fractured QRS. The QRS is still wide, but it's much more narrow than before. Okay, and again, the QTC is still prolonged. Like here's one peak on the QRS, another peak on the QRS, and the T wave is sitting halfway between there. The patient did very well, got admitted, and everything turned out to be fine. Here's what the literature has to tell us as far as similar cases go. Here's another case of flecainide toxicity. Okay. Here's the EKG. Here we go. 46-year-old woman with flecainide toxicity. Let's look at it. Okay. Number 1, the QRS is wide. Okay, we have this left bundle branch block appearance because it's down in 2-3 and AVF. The QTC is also prolonged. Okay. In between each R wave, the T wave follows. We also have this first degree AV block, which I'm not too concerned about. We also have this super large S wave in lead 1. Okay. I mean, if you look, it's, down in lead 1 and down in AVF. Some people might call that an indeterminate axis. This is why, as stated before in previous videos, anytime there's a large R wave in lead 1, I'm calling that a right axis deviation. Because, left axis deviation, I don't care so much about, but throughout this series, you'll see that new onset right axis deviation, especially when you have symptoms associated with it, I do pay attention to that because that can be associated with bad things. Same case after a dose of sodium bicarbonate, and look how all those things improved. I mean, there's still many conduction abnormalities, but look how much better it got, just after 1 amp of sodium bicarb. Look at the access. Look at that S wave go away. Look at the QRS narrow out. Look at that terminal R wave and AVR go away. A terminal R wave, the definition of a terminal R wave is an R wave greater than an S wave in AVR or an R wave greater than 3 millimeters. This R wave is not greater than the S wave, but it is greater than 3 millimeters in AVR. Terminal R wave in AVR is very non-specific. You can see it in the setting of any sodium channel blocker, like in this case. And look how much better that gets after the sodium bicarbonate. Did I mention that in Baker's case? Oh, Patrick. Yeah, I mean, yeah, it's hard to tell. I mean, you could call that a terminal R wave, but there's so much artifact, difficult for me to tell definitively. Another case from the literature with a flecainide toxicity, and again, similar presentation here, right? You could be tempted to call this ventricular tachycardia. From our previous videos, you could be like, ooh, look at that Brugada interval. The beginning of the QRS to the peak of the S wave and the precordial leads is super long. Ooh, look, there's an S wave bigger than an R wave in V6. Ooh, look, there's an indeterminate axis. It should be ventricular tachycardia. No, you can't do that for the 2 reasons. Number 1, the heart rate is less than 130. Number 2, the QRS duration is over 200. And this one also, this is totally like a terminal R wave. Look, there's almost no S wave, and look at that super huge R wave. So this is what I was talking about before. I had this slide up in a previous video, and I fixed it. So this is how I approach wide complex tachycardia. And again, this is why I think you should refer to it as wide complex tachycardia, because that encompasses many things, right? Saying you have wide complex tachycardia is like saying you have a car. I mean, what kind of car is it? I have a car and I have a 2024 Toyota Tundra are both true statements and accurate statements, but they're different statements. So again, wide complex tachycardia, if the heart rate is over 130 and the QRS duration is less than 200, then proceed down the ventricular tachycardia pathway. There's monomorphic ventricular tachycardia and polymorphic ventricular tachycardia. You can skip over this if you want to, but I think repetition helps build memory. The most common cause of monomorphic ventricular tachycardia is structural heart disease, specifically scar-mediated ventricular tachycardia. Under monomorphic, there's two subtypes. There is sustained monomorphic and non-sustained monomorphic, and the distinguishing factor is 30 seconds. Under polymorphic ventricular tachycardia, there's two subtypes, and the distinguishing factor is the prolonged QTC. Polymorphic ventricular tachycardia with a prolonged QTC is torsades. The most common cause in America is medications. Polymorphic VTAC with a normal QTC is just regular old polymorphic VTAC. The most common cause is acute coronary syndrome. The best medications, again, you can use any medication, well, not any medication, but there's many medications to use, but the ones that are the best, in my opinion, is for sustained monomorphic VTAC, procainamide, non-sustained beta blockers, polymorphic VTAC with a normal QTC is amiodarone, polymorphic VTAC with a prolonged QTC is magnesium. Now, the case we have here is we fell out of this pathway because we didn't qualify on the rate or the duration, okay? Again, if you see wide complex tachycardia, the rate is less than 120, or the duration is over 200, you should think accelerated interventricular rhythm. And again, in my opinion, in my experience, you should think about toxic problems like medications, which we saw in this instance, metabolic problems, which is either severe acidosis or hyperkalemia, or anything that affects connexin 43, which I'll talk about in abundance in later versions. Now, the reason this is important and the reason this can be dangerous is because if you get in certain situations for the underlying cause for the AIVR and you give them these medications that are designed for ventricular tachycardia, you can make it worse and even cause a systole. Like the classic one was AIVR is a reperfusion arrhythmia after successful reperfusion during a heart attack. And if you treat a person with lidocaine in that instance after they're reperfused, you can put them into asystole. And again, like here's where the overlap comes from. Accelerated ventricular rhythm, AIVR, here we go. Faster than 40, but can be up from 100 to 120, okay? So that's, the rates for AIVR, and you can read this stuff, and I put the website on here, and you can read the whole paper if you want to. And then here's ventricular tachycardia, right? Wide complex of at least 100 beats. Okay, so we have that overlap, that 100 to 120 area where there's an overlap where it could be either ventricular tachycardia or an AIVR. And the problem is if you treat one differently, you can have bad outcomes. That's all I have for this case, okay? The main teaching point here is remember, wide complex tachycardia, if the rate is less than 130 or the duration is over 200, stop and think. That's not ventricular tachycardia. That's most likely accelerated interventricular rhythm, and you proceed down a different pathway. For an accelerated interventricular rhythm, the most concerning cause is toxic, like from medications that you're prescribed, like this case we saw in flecainide, but it can be from either street drugs or over-the-counter medications. I mean, Benadryl can cause the same problem, and it's any medication that affects anything that propagates electricity through the myocardium, and that's either the sodium channels, the potassium rectifier channels, or connexin 43 at the gap junction, which we'll talk about later. And sodium bicarbonate was given in this case, and sodium bicarbonate works for flecainide by no one really knows, in my opinion. One of two reasons: either number one, it inactivates the medication or the channel by modulating the pH, or number two, it's the sodium that we're giving them that overcomes the blockade to fix the problem. I don't specifically know why. I'm sure Dr. Paskowski can tell you why if you ask him, so go bug him. And that's all I got for this case. If you have any questions, ask me in person. Peace out.